Today we'll discuss the principle of laparoscopy from the from the Telinde 13th editions operative gynecological book. So starting from the operative, what are the indications of gynecological indications for indication for gynecological indication laparoscopy? Starting, you will start from the if the patient having pain, if presence of foreign bodies and hysterectomy, if you plan for hysterectomy, adnexectomy and sterilizations and fertility assessment and treatment plan, endometriosis, you go for a laparoscopy, fibroids cases, you go for laparoscopy, and uterine and adnexal mass and pelvic adhesions, you do adhesiolysis, ectopic pregnancy, appendicectomy, cancer staging. These are the indications for gynecological indication for laparoscopy. So major important is preparation for laparoscopy. Patient selections is very very important. What are the contraindications you have to know before going to laparoscopy surgery? Because as all surgical procedure very very important, all surgical procedure appropriate patient selection is very important. That will reduce the surgical risk and optimize the patient outcome. Most patients are safe to undergo surgery, will be candidate for laparoscopy surgery, and careful selection is very very important because those who with the known medical comorbidities, that makes the procedure problematic in some patients. So what are the indication? Already we have read what are the list of contraindication for laparoscopy. You have to know there is two type of contraindication. One is absolute, one is relative. Absolute is those patients, you have to remember, in those patients that inability to tolerate, very very important step in laparoscopy, the initial step is pneumoperitoneum and the positioning of the patient. So if those patients which is unable to or inability to tolerate the pneumoperitoneums or Trendelenburg, steep Trendelenburg positions, that patient is not fit for laparoscopy. The next is if they have a severe increase intracranial pressures, because already you will give pneumoperitoneum, CO2 insufflation will always already increase the intraabdominal patients. Again, if there is increase in intracranial pressure, that will also not a, that is also contraindications for laparoscopy surgery. Next is abnormalities, abnormality of cardiac output and cardiac and pulmonary disease that will exacerbated by pneumoperitoneum or tunnel pressure. If those patient they having any cardiac issues like cardiac output abnormality or cardiac or pulmonary disease, that will cause exacerbated by the pneumoperitoneum and tunnel position. So these are the contraindication of laparoscopy. And if there will be hepatomegaly and splenomegaly, there is injury to the spleen or livers, so that also is a contraindications for, there is a absolute contraindication. 5 points. First is inability to create inability to sustain or tolerate pneumoperitoneum in those patients which tolerate pneumoperitoneum of tentative position, and those patients increase intracranial pressures. And abnormal, those patients having abnormality, those patients having abnormality cardiac output or any cardiac or pulmonary disease, that will be exacerbated by pneumoperitoneum or tentative positions, and hepatomegaly and splenomegaly. These are the 5 contraindications for laparoscopy surgery. Absolute contraindication. The relative contraindication is pregnancy based depend on the gestational, usually say a third trimester and fast is contraindicated, third and first trimester. And then if it is very very severe obese patient, there will be difficulty in trocar entry, and extensive pelvic adhesion, that is frozen pelvis, also a contraindication. History of ventral hernia surgery, because the if you port entry will cause ventral hernia surgery, there will be again recurrent hernia will there. Presence of large ventral hernia, presence of ventral hernia, history of ventral hernia surgery, or presence of large ventral hernia. These are the contraindication for relative contraindication for laparoscopy surgery. The next thing is operating room setup, that is laparoscopy requires specific equipment. In addition to the surgical instrument, the room will be well accommodated. A tower, a laparoscopy tower, which hold the carbon dioxide outflow and the camera base and the light source. Basically we have a camera base input and carbon dioxide outflow and light. So the tower may or may not be attached to the monitors or a screen which the surgeon will view through the case. Depending the area or operations, the pelvis or upper abdomen, the screen may need to be moved to that will allow the surgeon to view without craning his neck. The ideal setup for pelvic surgery is 1 or 2 monitors are placed near the foot end of the patients, and the room must also allow for a generator of some sort in which attach the electrosurgery instrument. It is imperative that all cords and cable be fixed or taped to prevent trapping entanglement. Okay, so cavity. So basically this is this is the camera input, and this is your light source. You can see this is the on and off switch. This is the 5% light source. it is increased to 40% during your white balance. And this is your CO2 insufflator channel. This is your light cable will attach here, light source. This is the CO2 insufflator channel has to connect here. And these are the three in this box. One is your set pressure. Set pressure has to be 16 to 20 mmHg during your primary toker entry. This is the total, this is the flow rate. It has to 1 to 2 liters per minutes. And this is the total volume of gas inside enter into the abdominal cavity has to be stored in here. When your set pressure is maintained, then the flow rate will be come to 0. When initial entry, the set there should be a negative set pressures, negative. Then the bed is ideally, the bed has to be in the center of the operating room, allowing the full movement around the patient. The bed must allow lithotomy positioning, the ability to tuck the patient's arm also on the side of the patient, and it allow change in patient height, tilt, and position. There are variety of material, like more expensive commercial available options like air mattress to bean bags, foam pad with attached velcro straps to support the patient body and your shoulder. These are the Velcro inexpensive egg crate is placed on operating room table to decrease the patient movement when placed in turning positions. And the patient should be placed in operating room tables in a low rhythm positions once anesthesia has been induced, and the legs should be in supported by padded stirrups, buttock at slightly below the inferior edge of the table so that the vaginal access will be better. The angle between, very important angle is angle between the thighs and abdomen should not be, it should be around 170 degree, and hip flexions to one extent is to less than 150 or more than 180 will increase the risk of knob injury. Angle of the knees should be between 90 to 120 degrees, and the hip abduction is not more than it should be less than 90 degree. That will prevent knob injury. The toes, very important, the toes of the patients, and the ankle and your knees should be, knee and the umbilicus and the contralateral shoulder should be in a single line. Okay, contralateral shoulders should be in the single line. That will cause a positioning that will prevent everything. The most surgeons stock both arms next to the patients in a military positions, and that will allow free movement around the operating tables. The patient surgeons can move by not extending the arm, the side of the neck. It will prevent brachial plexus injury, also reduce the neck shoulder angle should be 90 degree to avoid overstress, and the bony prominence has to be padded properly, and depending on the planned surgery, the bladder catheterization has to be done. And sometimes some surgeons prefer to do orogastric or nasogastric tubes if you are planning for place the port or trocar in the Palmer's point, that is 3 centimeters below the mid clavicular lines. Okay, 3 centimeters below the mid clavicular lines in the from the GP from the mid-clavicular lines. Intraoperative uterine manipulations require certain procedures, adequate visualization. These are the manipulators, these are the instrument. You can see this is the first one, uterine manipulator from left to right is Acorn uterine manipulator. This is the Acorn uterine manipulator. This is the uterine tenaculums, and this is your Jumi manipulator and advanicular delineators. These are the manipulators. Okay, what are the basic equipment? Usually when you go from a normal open surgery to a laparoscopy surgery, the basic equipment has to be changed. And very important here, we are using the carbon dioxide gas as a distension media, because the advantage is that it is rapidly absorbed by bloods and has a no long-term effect on metabolic status of the patient. And the target pressures, very important, the target process for most laparoscopy surgery in generally healthy adult patient is 15 mmHg. And very important, when you how you know that your Meris needle is inside the abdominal cavity or it is extraperitoneal. So opening pressure is very important. If it is a negative opening pressure, then it is inside the intra-abdominal cavity. If it is a very high positive pressures, then it is more than 10 mm, then it is outside the peritoneal cavity or ends there. So, and the instrument, like the basic instrument is camera head and laparoscope, light source, and compromise the remainder of the standard equipment. And the laparoscope diameter is varies. It is from 1.8 to 12 mm are available with various viewer angles like 0-degree angles and 12-degree angle, 30-degree and 70-degree. So most laparoscopies perform, usually we are performing with 5 mm or 10 mm with the 0-degree scope, and the light source is fiber optic cables which attach the scope. and that it will transmit light from high intensity light source such as xenon or halogen. The end of the cables attached to the scope can extremely hot, uh, so can cause skin burn, so very use cautiously. Other laparoscopy instrument, the accessory port has been used for the instrument insertion like blunt fork, grasper with and without teeth, curved or straight or blunt tipped or pointed tips instrument like tenaculum, bowel retractors. And for a tooth grasper should never use to retract bowel because it will cause injury to the bowel, so very important. So these are the first instrument is your Maryland grasper. So first instrument is your Maryland grasper, the second is your atraumatic grasper, and third is your biopsy forceps, and fourth is your bowel grasper. Okay, these are the instrument. And so basically the Maryland dissector is used when grasping small pieces of tissues, tissue when separating planes, such as during ovarian cystectomy. And a traumatic grasper provides excellent grip and does not traumatize the tissue. And biopsy forceps are a small tooth which can provide added grip but doesn't create small puncture. Bowel forceps allows a traumatic manipulation of the bowel and can decrease the injury. Used in blunt dissection. Laparoscopic seizure also available, that is reusable, disposable. They can be cold seizure, that is not attached to electric surgery generator, fitted with, or it can be fitted with monopolar cord, be a source of electric energy, as well as cutting device. Scalpel, laparoscopy scalpel, monopolar bipolar hook, spatula, stapler, harmonic scalpel, bipolar cutting device. These are the devices to be used. And not taking intracorporeal extracorporeal knots. And very important, more recently these are the very important, that barb sutures has been become more popular because the least commercially available barb sutures. This advantage is that it will ability secure the suture without knot tying, very important, because we are difficult in tying the knot. So they have and when this, if the suture is pulled through the tissue with the barbs pointing out from the needle direction of the needles, then it is tightened the tissue. Barb catch the tissue hold. Barb suture is popular choice by vaginal cough closure and hysterectomy and closure during myomectomy. The laparoscopically surgical clip applies are available in variety size, endosurgical clips and vascular pedicles by here. Okay, so thank you.